When we talk about the interbody fusion, whether this is an anterior or posterior depends on whether what you're doing in regards to the transverse process. If you're going anterior to the transverse process, that is a bony landmark for us. If you're going anterior to the spinous process, that becomes the anterior surgeries. And if you're coming posterior to the transverse process, that forms the posterior surgery. So my friends, remember, transverse process is a key bony landmark which will decide whether the surgery that you're doing is going to be called the anterior or the posterior surgery. So anterior to the spinous process, the different options are going to be A-lift, O-lift, and L-lift. That is the depending on which, if you're going bang on anteriorly, that is the A-lift. If you're going anterior to the psoas, that is O-lift. If you're going through the psoas, that is L-lift. L-lift is also called as X-lift. Posterior options that are posterior transverse process, they would include P-lift, T-lift, and MIS T-lift. So most commonly the surgeries that are done today are MIS T-lifts, I would say, and O-lifts. Now, as I told you, it depends on from where you approach the spine. If you're approaching bang on anteriorly, that is A-lift. If you're approaching anterior to the psoas, that is going to be O-lift. Through the psoas is X-lift. Posteriorly, P-lift and T-lift is something. If you're going through the foramen, that is T-lift. Bang on posterior is P-lift. So the objective is the same. You do a thorough decompression and you achieve a fusion. It depends on from where you're exactly approaching the spine. That makes a difference. MIS T-lifts, so minimally invasive T-lifts, we put in guide wires. This is how I do. I put in guide wires where the screws are going to be. Then I do the interbody and the disc wire, do a proper decompression. Then we put in the screws and the rods. And the best thing about MIS T-lift is that via bending the table, we even do the over the top decompression and do the decompression on the contralateral side very easily as well. So this is how most commonly MIS T-lift is being one of the major surgeries that is done regularly for such types of pathology. Now, LF is transverse corridor. Generally, LF is not suitable for L5S1 because there is a risk of the injury to the lumbar plexus and the psoas injuries can happen. So, as you're seeing over here, whenever you're going through the psoas muscle, there is a high chance that you may develop the injury to the lumbar plexus or the psoas injury. O-lift, you go anterior to the psoas. A-lift, when you're going bang on anteriorly. A-lift, there are risks that are involved in regards to injury to the IVC, and in OLIF the injury to the ureter, which are very dreadful complications. That is the reason why most commonly TLIF and MIS TLIF is done rather than the ALIF or the OLIF. Now, when we compare ALIF and TLIF, dural injury is significantly lower in ALIF, blood vessel injury is higher in ALIF. Radiologically, ALIF may be superior to TLIF. Significant indirect foraminal decompression, restoration of disc height and foraminal height is something that can be achieved via ALIF. PLIF versus TLIF, neurological deficit, graft position, durotomy would be higher maybe in PLIF. Clinical satisfaction, blood loss, nerve root injury, graft malposition, infection, and radiological fusion are similar both in PLIF and TLIF cohorts. So, both would show more or less the same results. Why is TLIF more commonly done? Because you don't retract much of dura in that. PLIF requires some retraction of the dura. Hence, TLIF is generally more commonly preferred over PLIFs. Sagittal corrections, once we talk about ALIF is better than LIF is better than TLIF. So the anterior lateral groups both significantly improve from lordosis and post-op and in follow-up, whereas the TLIF cases did not improve to that extent as what the anterior surgeries did. So generally, if you talk about recommendations, so as you're saying, pelvic surgery that is recommended at all the areas starting from thoracolumbar to lower lumbar spine. TLIF is again something that is recommended at all the levels. ALIF is not recommended at L2, 3 and dorsolumbar levels. LIF is not recommended at L5S1 levels, can be done at other levels. OLIF, dorsolumbar levels again is a fair option, not a very good option. Instruments for the lumbar spine, transforaminal lumbar interbody fusion. I would recommend you to go through these instruments because these are the instruments that are asked you in the exam commonly, and they even ask you these steps of TLIF.